Okay, I will just. Good morning, all. We are welcoming you for the second day of JICS 2024. And we are going to start up with a very interesting topic of battle against sepsis to wake you all up from this moody morning of very good climate. I welcome the Chief Moderator, Dr. Rajesh Shetty, Chief of Clinical Services, Manipal Hospital, Whitefield, to take the dais, please. I welcome the chairpersons, Dr. Nirdesh Thakur, Assistant Professor Anesthesia and an intensivist currently, Dr. Vishal Shanbag, Associate Professor, Department of Critical Care, Kasturba Medical College, Dr. Varun Arora, Consultant, Surgical ICU, Rajiv Gandhi Cancer Institute and Research Center, Rohini, New Delhi, Dr. Sudeep Singh, Apollo Hospitals, CBD Bellapur in Mumbai. I welcome you all to the dais, and we will start up the session.
Yeah, I'll show you. I'll introduce the first one. You want to introduce one? No, we'll introduce Sachin, sir.
That will come here.
Now the Chief Moderator, Dr. Rajesh Shetty, will take over from me for the introduction of the speakers.
Thank you, Dr. Menaka. Good morning, all. It would have been nicer if more people are there, but in the interest of time, I think we'll get started. As all of you agree, sepsis is part and parcel of life of intensivist. Either patients will get admitted with sepsis or they will develop sepsis in the course of their ICU stay. As per the estimate, about 30% of patients in ICU at any given time will have sepsis. And mortality is very high, despite all the progress we have made. We have a very good session coming up titled Battle Against Sepsis. So I think without wasting much time, we'll get started with the session. I would like to invite Dr. Ram Rajgopalan to give the first talk on phenotype-based sepsis management. Are we there yet? Over to you, Dr. Ram Rajgopalan. Thank you.
Good morning. This is going to be almost like a classroom session. Probably some of my classes are a little bigger than this. But as much as it is disappointing not to see enough people in the audience, I thank you all who made that effort to come and listen to the presentation, as I'm going to do it right now. Okay, the idea of subphenotypes is something that is probably going to grow on us over a short period of time. And definitely there is a need for us to understand the very rapidly growing research that has been taking place in the recent past. I'll start with a clear-cut disclosure that I'm no expert in this area. I'm effectively an informed consumer. And I don't have any expertise either in artificial intelligence or in the analytical methods of phenotyping. And definitely, this is not a peer-reviewed presentation, and as a consequence, may marginally mislead you. Try to be very careful. I'm trying very seriously to grapple with this issue that is going to become a very relevant part of our management in the future. We know that the secular trends of mortality in sepsis over a period of time has definitely been in a downward direction. But what leaves us a little bothered is, despite the kind of changes that we have seen, there is still a very large residual mortality that is related to sepsis. And as a consequence, we need to find ways in which we can handle this excess mortality. Very clearly, the clinical studies that we look at that attempt to do this have created a whole amount of problem. A treatment that was considered the best treatment of the year in 2001 subsequently has been declared as an invalid kind of a process. And very clearly, heterogeneity clearly limits the replicability of many of our studies. Most of these studies are based on patient populations that are phenomenally heterogeneous. And as a consequence, when repeated, are not consistent in demonstrating the benefits of specific therapies, even when the therapies are physiologically completely rational. So with this as the primary concern, we have always gone through a process of trying to say that we can't keep these patients in a heterogeneous lumped group, that we need to find a way in which we can split them into subsets or into subgroups, which will have reasonably identical behavior, and therefore we can test whether specific treatments will be worthwhile under these conditions. Now, the simple way in which we typically do this is to look for associations between, say, a specific outcome, either mortality or a need for ventilatory support, and the baseline variables, classically things like age, oxygenation, SOFA scores, all of this we are reasonably familiar. And we try to be a little bit more sophisticated in converting this into some kind of a multivariate analysis process, and ultimately developing a risk stratification strategy where we give different weights to these significant associations and ultimately try to say, oh, we have discovered groups of people who have higher and lower risks, and therefore these patients probably should respond to treatments in an identical kind of a fashion. Now, there is a problem with this. Very commonly, the parameters that we look to see associations with a bad outcome, whether it is death or going on a ventilator, are almost always factors that occur later in the course of sepsis. This is something that will occur at a time when the patient has an advanced sepsis, the cytokine levels are massively elevated, the hemodynamics is severely compromised, and it will almost always be late in the process. I'd almost argue that it doesn't take a genius to figure out that a patient who's really looking very sick is going to die. And that's effectively what we are doing under these circumstances. There is very clearly a time dependence and a severity dependence in the way in which we look at these parameters. We need to have a method by which this delayed recognition of different categories of patients has to be avoided, and that we need to identify patients on the basis of characteristics that are both early and which are stable over a period of time, what we consider as temporal stability in terms of these parameters. And very simplistically, the method that we use right now is what is called cluster analysis. When we have a heterogeneous group, we recognize that there will be quote-unquote latent subgroups of individuals who have very similar characteristics. I liken it to the blondes and the redheads and the brunettes that we can easily identify as being very similar to each other. And cluster analysis attempts to identify these hidden structures. It has no a priori knowledge of how many of these subgroups are present, and it requires a lot of complex mathematical and analytical techniques which are hugely amenable to artificial intelligence kind of processes. So I think we just need to be not very turned off when we see an AI kind of an idea in it. The ideas behind cluster analysis are extremely simple. If you really look at it, Prashanta Chandra Mahalanobis, long time ago, developed some of the methods of cluster analysis. The big advantage that we have had right now is our computing power has grown up so much that we can identify multiple factors in the cluster analysis. Effectively, what you're trying to say is, do these people look identical, or in their intra-cluster distance is very small, and do they look sufficiently different from other groups? So the inter-cluster differences are reasonably large, and that is what we need to try and identify. But cluster analysis by itself is not the definition of a phenotype, because in phenotypes in medicine, not only do we expect to be able to identify patients on the basis of these kinds of descriptive attributes, we also need to have the ability to show that these isolated groups of patients have a meaningful outcome. There is an added expectation that a cluster that will respond differently in terms of mortality and will respond differently in terms of the treatment is probably very essential. So a subphenotype is a cluster that has what is called phenotypic discrimination. The phenotypic discrimination can be both prognostic in which case they will, a person in a specific phenotype will have a different mortality from somebody in a different phenotype, or they will also have a predictive discrimination, or the response to a specific therapy will be distinctly different if they fall into different phenotypes. With this as the broad idea, the ideal phenotype that we need in clinical use has to be for at least having these 4 minimum characteristics. Number one, it should be highly discriminant. It should not be something where there is a tendency for an overlap. Say, for instance, if I look at oxygenation as a parameter, I can have patients with varying grades of oxygenation, and attempting to divide them into subgroups can be associated with tremendous overlap. So what we need to have is clearly discriminant traits, and here cluster methods are absolutely fantastic in making that distinction. We have to have temporal stability, that the identified characteristics should be fixed and should not change over time, especially with the treatments that are being administered to the patient. This is classic. If you use something like a cytokine level, for instance, it will change over time, and it can't be a great method for inclusion in a cluster analysis of a patient. There should be minimal migration between the subgroups, and there should be both prognostic and predictive discrimination of all these subsets. And this needs to be derived not only from retrospective databases, we need definitely to ultimately achieve it in a prospectively validated randomized controlled trial of some kind. Okay, now I will go through whether we meet any or all of these criteria with the current ways in which we look at the phenotypes in sepsis. Well, the phenotypes in sepsis, if anybody talks about it, I think we need to be very clear that this Christopher Seymour article with Derek Angus being the god who was coordinating this is very important. Is what is called the Seneca study, where what they did was they looked at traditional commonly available parameters on sepsis: age, sex, comorbidities, basic biochemistries as an included factor, and they used a complex AI-based cluster analysis methodology to try and differentiate these patients into subsets of what you call as phenotypes under these conditions. They were able to identify 4 very specific phenotypes, what is called the alpha to delta, alpha, beta, gamma, and delta, where the alpha was clearly a good phenotype. The outcomes in these patients were really very good, and the delta was usually associated with terrible outcomes. But they've also noticed that the organ dysfunction characteristics in each of these were distinctly different. So there were different subgroups of patients who were identifiable as the phenotypes. And I won't go through the process of cluster analysis, but I can promise you that what I'm trying to show you over here is that the cluster analysis and the comparison between groups shows you a dramatic difference between these subsets. They are clearly identified as distinct separate groups. There's no question about it. Second, if you really look at it, does it have any prognostic enrichment? It does have it, in the sense that if you're in the alpha subgroup, your mortality is significantly lower than when you're in the delta subgroup. They didn't have any way in which they could test the responses to treatment, so they effectively did a simulation. They used a Monte Carlo simulation of mixing these phenotypes in different levels and testing it on data in which the EGDT studies, which initially showed no differences in outcome, but when they changed the phenotype structures, they could demonstrate that if there was a delta phenotype excess, the tendency to create a harm was a lot more. And in case there was an alpha phenotype excess, the tendency to create a benefit was also establishable. So there was definitely some kind of a phenotypic enrichment also that was seen in terms of the predictive capacities of these phenotypes in terms of the therapies. But the problem that they faced, unfortunately, is when you look at these phenotypes, okay, the alpha was dominantly associated with Apache scores that were lower, and the delta was associated with Apache scores that were higher. And to claim that these are different from Apache-based discrimination methods is something that I will really question. Though they claim that it is different, I feel that the associations are too strong for us to ignore it. And this is natural because they used a lot of parameters that progress with time. and particularly your cytokine levels will probably be also associated with severity levels. And to use something like that in a cluster analysis is probably frankly illogical. I have to clearly admit that they didn't leave it at this stage. They have gone through multiple other ways in which they can assess it. And one of the nice things that they saw is, for instance, the cluster analysis that we see in routine patients, in routine sepsis, is very extrapolatable to patients with COVID. So even in COVID, they were able to identify the same alpha to delta subphenotypes. And they were also able to show that besides the mortality differences, that they were able to show treatment differences. For instance, response to steroid was very classically in the sigma, in the delta kind of a subset, in contrast to the other subsets, seeming to imply that there is some value to this. But the biggest problem that I continue to face is the fact that these subsets, these phenotypes are not stable over time. In this particular study, they will show you that when they included parameters of pathogen-related factors, okay, it's like the site of the organism itself and the antibiotic resistance patterns, it significantly changed the number of patients in each of the phenotypes. By definition, a phenotype is a characteristic that should be fixed for a given patient. And if it changes with either treatment or time, it is not a true phenotype in that sense. And even though they say the significance of these changes and they're important for treatment remains uncertain, I am reasonably certain that this implies that these parameters are not time invariant. And ultimately, this is one of the best studies that we have. And if I was to be a school teacher over here and grade this study, I give this only a 2 on 8. I'm looking at all the parameters that I have, okay, and even my Hindi score, Hindi school marks were better than this. Okay, I used to get about 35% all the time. This is not even that. Okay, is there another way in which you can look at phenotypes? And this is something that we need to also understand. In this initial analysis, we said we need to look at fixed characteristics. I'm going to ignore that. We'll look at fixed characteristics that don't change over time. The argument will be, if somebody has an increasing cytokine level as a function of their worsening of their clinical status, it depends on the time when you pick them. If you pick them early, they'll have a low cytokine value. If you pick them late, they'll have a high cytokine value. And you can't use that to define the subgroup in which the patient actually falls. It is a marker of severity and a marker of time. Okay? And people have a tendency to ignore these kinds of parameters. But we can use this kind of information as well in what is called group-based trajectory modeling, okay, where you look at the direction of change. If somebody comes in with a low cytokine level and changes within an hour to a much higher value, there will be a different implication than somebody who doesn't. And that could be used as a phenotypic kind of a marker. So the early assessment of change can be subsequently used as a marker to judge whether the patient is, in one subset or another. And in this sense, I think I need to attribute a lot of the reading that I've had to this individual, Shivasubramaniam Bhavani, listed as Dr. Bhavani. I always thought it was a female, then I looked at his CV, and it's a young guy who was in the University of Chicago, who effectively looked at these, phenotypes in form of the trajectories. And what he showed is a very simple kind of a model. It's a good model, okay, where he demonstrated that the existence of hypothermia and hyperthermia and its patterns of resolution have significant differences in the prediction of mortality and are probably true phenotypes. Unfortunately, this has not been extrapolated to therapeutic kind of endpoints, but this seems to be quite convincing, something that we can look at very easily. So a hypothermic patient we expect will be definitely patients with a higher mortality, but he also showed hyperthermic patients who take a longer time to resolve their temperature are worse off than patients who have a quick resolution of their hypothermia. And as a consequence, he could make a differentiation between these subsets. Very similarly, SBP-based trajectories have also been used. And here, again, it has not been evaluated for predictive responses, but mortality differences between the varying classes have been reasonably identified. I like, again, Subramaniam's another article where he used a combination of parameters, temperature, heart rate change, respiratory rate change, and blood pressure change, And he classified them into 4 phenotypes, which had clear-cut differences in terms of their mortality. But also, what was also interesting is there was a predictive enrichment in the sense that in patients who were treated with balanced crystalloids, they had an outcome that was beneficial in one group versus another. And that, again, is reasonably a good idea in terms of the evaluation. The one place where the Seneca people made a little bit of a mess was when they added cytokine data and they did the same old kind of latent class analysis in their Seneca data. They claimed that they were able to identify subsets, but I have a big problem. You're combining a time-based trajectory with a fixed trajectory, and as a consequence, this is not exactly the world's best study. Remember that subsets, phenotypic subsets are not only been derived in sepsis, they've also been derived in patients with ARDS. And here again, this is probably a landmark and a classical paper. Carolyn Caffey, who's basically dealt with this, very clearly identified 2 subsets of patients, what is called the hyperinflammatory and the hypoinflammatory subsets in ARDS. And this has excellent prognostic enrichment. It has got excellent predictive enrichment, and is probably the only one that has been tested to see that it is time invariant. And in that sense, it also meets that characteristics. So when we apply this same kind of phenotypes even to patients with ARDS, I'm sorry, I seem to have lost my slide over there. Okay, they were very clear in demonstrating that this ARDS phenotype can also subdivide patients with sepsis and can be of value. Likewise, it was also seen in COVID, and it also had the prognostic ability to differentiate between individuals who respond to steroids and those who don't respond to steroids. So if I were to broadly look at it, if you and I, as the common man, is going to be given this set of data and asked to say, are we going to apply it? Very, very clearly, we know that we can't derive these phenotypes easily by just looking at individual parameters. And that scares the hell out of us. The second thing that we also understand is there are multiple phenotypes even for sepsis, whether you look at the trajectory base, whether you looked at the Seneca, or whether you looked at the P1, P2 of the ARDS group. There are multiple ways in which you can define it. And the question is, are they distinct from each other, or do they have characteristics where one is superior to the other? We don't even know that in the first place. And additionally, because there are multiple characteristics, which one do you use? The complexity of phenotype analysis in septic patients becomes even more complex. There have been attempts to simplify some of this, and in fact, I think there is a group in Calicut who's probably involved in a RCT that has been using the simplified parameters. I don't know whether it's the parsimonious model or whether it's a clinical prediction model, but basically it's a simple model that we can use to make the predictions of these phenotypes and probably have it evaluated in a prospective way. And I think we need to wait for those results, definitely. So are current subphenotypes ideal? Are they highly discriminant? Because we're using cluster analysis methods, they are highly discriminant. There's no question about it. Is there temporal stability that occurs over a period of time? I'm not very sure. Some of these studies have shown it, some of the studies have not shown it, and therefore there is definitely a problem. Is there minimal migration between subgroups? As I showed you in the Seneca study, there's a phenomenal amount of migration, and therefore it's not very effective. And if we really look at the prognostic and predictive discrimination, they vary depending on the kind of studies. And none of these studies have been tested in prospective randomized controlled trials, and therefore probably are not completely ready. So if you ask the same question that my kid always asked when we got into the car, as soon as we get into the car, they say, are we there yet? Are we there yet? No, we're not there yet. We're still very far away from achieving our endpoints. Thank you very much for the extra time that you've given me. I hope that was a clarity.
Thank you, Dr. Ram. We'll take the questions after the end of the session. We'll invite the next speaker.
Good morning, everyone. Today, I'm going to introduce a person that is very dynamic and knowledgeable. The topic is antibiotic. Sorry. Okay. Right, I want to call Dr. Mona Lisa. Please come and
Thank you, Dr. Nidesh, for this kind introduction. So my topic is quite interesting, change in strategy of antibiotic infusion in sepsis. So there have been so many RCTs and systematic reviews and meta-analysis, but unfortunately not many things have shown actually difference in outcomes. So despite of that, we are going to go through this that, is there any point of changing our strategy from intermittent boluses to continuous infusion? So just for my knowledge, I'll ask the audience, so how many of you are using extended infusion or prolonged infusions of antibiotics in ICU? No one? Only one person? Even for beta-lactams, vancomycin, nobody is using prolonged infusions, extended infusions? Okay, so so there are a few hands. So we'll just go through this topic and learn the advantages of using continuous infusions. So continuous infusions especially are important for beta-lactam antibiotics, especially if it's a gram-negative sepsis. Beta-lactams, as we all know, exhibit time-dependent bactericidal activity, and continuous infusion, the main role is to maintain the drug concentration above the minimum inhibitory concentration of the relevant bacteria for a prolonged period of time. So this increases the probability of clinical cure and potentially could reduce the risk of resistant stains developing. Beta-lactams continuous infusion also have a role in outpatient parenteral antibiotic therapy, where there's an additional PK/PD benefits. Once daily administration can also be cost effective. So understanding the pharmacodynamics of antibiotics. So we all know that beta-lactams are basically supposed to exhibit time-dependent killing, and the serum concentration of this has to be above the MIC for a longer period of time. Can anyone tell me for beta-lactams what is the expected time for which the free drug concentration should be above the MIC? What is the percentage of time that is ideal? Any guesses? Yeah, so it is somewhere between 40 to 50% for most of the beta-lactam antibiotics is what they expect is ideal, and it decrease in serum concentration below the MIC will lead to reduced bacterial killing. And of course, it also increases the risk of antibiotic resistance. So there are definitely some theoretical advantages of using continuous infusions of antibiotics or extended infusions of antibiotic. So let me give a brief understanding of what they are. So the first thing is standard intermittent infusion, that is 30 to 60 minutes, which we have been using for many years now. And then comes those standard infusions will create peaks and valleys in the drug concentration when administered over this duration. Then comes the prolonged infusion of 2 to 4 hours. They can provide more consistent serum levels. And then comes the continuous administration, which actually will achieve the serum levels consistently above the target pathogen's MIC. Okay, why is it important to actually have continuous infusion or extended infusions? The reason is that, as we all know that the beta-lactam antibiotics show time-dependent killing, as we all can see that the free drug concentration in the first chart, the free drug concentration should be above the MIC for most duration of time to ensure proper killing of the antibiotic. So as you can see, there are two graphs here. The blue one is actually showing the extended infusion, and the red one is actually showing the continuous infusion. So as we can see that in this case, that continuous infusion is the best way, because constantly the free drug concentration is above the MIC. And that is basically the most important PK/PD characteristic consideration which we need to keep in mind, and that correlates best with the bactericidal activity. So for a non-critical patient, it is not so important. Okay, we need not bother if the patient is not in ICU, the patient is in the ward status, 40 to 70% of the time the free drug concentration above the MIC is also fine. We need not bother. But it is very important in severe gram-negative infections in critically ill patient that the free drug concentration is 100% above the MIC. Higher dosing has minimal effects, extent of bacterial killing. Beta-lactam's 100% of free drug concentration, more than 4 to 8 times of the MIC is what is actually emerging as an evidence. No benefit of higher drug concentration above the MBC. Drug levels below the MIC at the site of infection resumes bacterial regrowth. And so, concluding all that, the infusion time definitely matters to prevent bacterial regrowth. And the time-dependent concept works in gram-negative infections mainly. So what are the implementation considerations we are worried about? So theoretically it sounds good, right? I mean, giving over a prolonged period of time or continuous infusion will help us achieving the free drug concentration above the MIC. So first we need to have some considerations in mind. Number one is vascular access. You need to have a central line and you need to have a dedicated lumen of your central line to make sure that this is going in a continuous manner. So the more number of lumens, the more infectious complications, the more thrombotic complications, that could be one of the issues. So the other thing is drug stability. So always keep in mind that we have to evaluate the stability of meropenem and piperacillin tazobactam while giving over continuous infusions. So read the manufacturer's label. Most of them are stable either for an 8-hour interval or a 12-hour interval. So if you want to give a continuous infusion over 24 hours also, you can break it up and like give an 8-hour infusion, then again reload and give another 8-hour infusion 3 times a day. Or if it is written as a 12-hour infusion, then definitely you can give twice a day as a continuous infusion. So we have to keep in mind the drug stability. Then of course the drug compatibility. We have to keep in mind that whatever other drugs are going are compatible with the antibiotic or not. Also the workload implications, like is the nursing comfortable? Are they actually, you know, in ICUs we have 2:1 ratios, sometimes 3:1 ratios in, you know, busier times. So are they comfortable? Are they okay to actually manage the continuous infusion of antibiotics? And educational implications. Do they understand the importance of why we need to give this? Why do we need to give continuous infusion or extended period of infusion of beta-lactam antibiotics? So these are the few considerations we need to keep in mind while actually practicing this in our ICU. Some incompatibilities, you know, we always be in touch with your clinical pharmacologist and you have your rounds with your clinical pharmacist and, you know, make sure that they're actually looking at what drugs are going with these antibiotics and they're actually compatible or not. Some examples of incompatibilities which we need to avoid in our daily basis. And of course, the nursing, you know, it is very difficult to make sure that they're aware of, you know, these considerations. So always have a round with your clinical pharmacist and the nursing team together to avoid this kind of incompatible drugs being given together. Okay, so all this sounds good, but unless we give you evidence, shouldn't believe anything what we are saying. So I'll try to give some evidence to believe why continuous and extended infusions are better. So first I'll talk about a trial which actually came in 2015, Blink True trial. So basically the Big 2 trial included 432 patients with severe sepsis across 25 intensive care units in Australia and New Zealand. And unfortunately, they actually compared the intermittent boluses versus continuous infusion, but they did not see any clinical, no significant clinical improvement was found, and this did not translate into a mortality benefit of 90-day as well. So then actually came a systematic review and meta-analysis in 2018, and what it showed is basically 31% reduced risk of mortality was actually seen with prolonged infusion of piperacillin tazobactam associated with a 31% reduction in mortality risk among critically ill patients. The sample size was actually quite good. It was 3,401 patients which were actually included in 18 different retrospective and prospective studies, and there are around 18 studies which were included, and they did show a difference in mortality. Then came the Surviving Sepsis campaign in 2021. What does it say? So it said that cautious implementation of extended infusion of beta-lactam antibiotics is important. Initial loading dose should be always given. Now please do not change your practice for initial loading dose. That initial loading dose has to be given quickly to achieve effective drug concentration. Then there is, they have shown a preference for extended infusion over a traditional intermittent administration method. But it is a weak endorsement reflecting a cautious approach, and there is moderate quality of evidence to back it up. Then came the Mercy trial. So Mercy trial actually included 607 septic ICU patients. 70% prevalence of gram-negative organisms was actually included in this. Mainly Klebsiella and Pseudomonas were included in this. But unfortunately, it did not show any statistical significance in 28-day all-cause mortality and emergence of pan-drug resistance or extensive drug-resistant bacteria between the two groups. So 90-day mortality, again, there was no difference in drug resistance. Then came the Blink-3 RCT and systematic review support, so which compared the continuous infusion versus short intermittent infusion of piperacillin, tazobactam and meropenem. The study population was around 7,000, and again it actually was supported by the systematic review which I mentioned earlier. But unfortunately, if you see the primary outcome, the mortality in the continuous infusion group was 24.9% and the intermittent infusion group was 26.8%. So I'll just take one more minute. So observed difference in 90-day mortality between the two groups did not meet the statistical significance in primary analysis. So I'll just conclude my thought on this prolonged beta-lactam dosing. So prolonged beta-lactam dosing is still preferable theoretically. There is a lack of harm which we can actually say. Potential benefits are there if you consider the PK/PD characteristic of beta-lactam antibiotics in achieving the free drug concentration above the MIC, ensuring bacterial killing and also reduction in resistance. Future research needs to be done in optimizing the dose regimens and broader implementation of these extended infusion needs to be done in our critical care units, and need for further education and training of the healthcare professional on the benefits and logistic of extended infusion. Thank you so much.
Thank you, Dr. Mona Lisa, for an excellent talk. We'll go to the next section now.
The next session is a tri-bait, for which I'll invite Dr. Shivkumar, MN, and Dr. J.V. Peter. Yeah. First, Dr. Shivkumar. So, Dr. Shivkumar.
It's okay.
Yeah, start.
Good morning. Greetings from Coimbatore and my institution, Royal Care Super Specialty Hospital. It is indeed my pleasure to be here. I'd like to thank all my friends for the kind invitation. Let me start by acknowledging my teachers who taught me anesthesia and critical care medicine. In the next 8 to 10 minutes, I'm going to reiterate the fact that antibiotic administration within 1 hour reduce mortality in sepsis is a myth. Hope you all agree with me. I think when this topic was given to me and I saw Dr. Peter is going to talk against me, I think this out I felt like. And I was thinking, why Pradeep keep doing this to me? I've been always very nice and fair to him. But somehow I gathered courage and I'm here in front of you. I don't have to introduce Peter sir. I think most of you know him very well. He's a great teacher. He's been a great administrator as well, and it is a proud moment for all of us. He's been the director of CMC Vellore for the last 5 years, and he's a great researcher. But I like to caution you, don't get carried away by all this. I think today he has come here for a wrong cause. I think you need to stay awake. To start with, antibiotic administration within the first hour of sepsis, is it feasible? Does it reduce mortality? Is this practice going to do any harm? And do you have evidence for all of this? Starting with the feasibility of this approach, is it feasible to reach the emergency room in an hour, to have a diagnosis of sepsis and to receive antibiotics? How many of you here agree all these three can be done within an hour? Do you all agree? The couple of hands up. I think most of them disagree that this is feasible within an hour. Even if Dr. Peter sir want to take the timeline from the diagnosis of sepsis, I think it is going to be very difficult. If you take the population per se, the health education, the awareness about sepsis is much, much lesser compared to a stroke or compared to an acute coronary syndrome. Needless to say about the pre-hospital transport system we have in our country to reach the hospital. I think it all started with this. In 2016 guidelines, they gave a very strong recommendation to administer antibiotic within first hour of diagnosis of sepsis and septic shock based on a very moderate quality of evidence. So this is a very interesting paper. This was published in the European Journal of Emergency Medicine. They simply looked at how the patients with a diagnosis of sepsis, they reached the emergency room. It was done in Germany. Believe it from me, from this paper, only about 50% of the patients used emergency medical service, and even these 50% of the patients, probably the diagnosis and treatment was not made in appropriate time window. So I think probably you could imagine in our Indian setting, the pre-hospital transport system and how early they could reach our ER. This is another interesting piece of work, and what they did was they did a survey among intensivists and they gave clinical vignettes and they asked them to make a diagnosis of sepsis. And to all our surprise, if you look at the one on the bar diagram which is colored in brown, I think this is the one where the intensivists are certain about the diagnosis of sepsis. Very minor number of responders are very certain with the diagnosis of sepsis. So it is not easy even to a trained intensivist to be very certain about the diagnosis of sepsis. To make things worse, in this paper, they looked at the diagnosis of sepsis and septic shock. About 1/5 of the patient, when they looked at 24 hours down the line, many of them who are diagnosed to have sepsis did not have sepsis, and there were a lot of sepsis mimickers, which I have listed on the left side of the slide. I am sure by now I reasonably convinced you it is very difficult to reach our ER room quite early with the diagnosis of sepsis, and it is not so easy to make a diagnosis of sepsis. Coming on, whether it is associated with the reduction in mortality. Many of these studies, I think, which say that I think it is a crime if you give antibiotic more than an hour or every hour counts, all these papers were retrospective analysis. And many of them, they have done a complex adjustments to find a mortality difference, and they have also incorporated some treatment windows like more than 6 hours, which is not the routine case. Peter sir, I have taken all this prospective analysis from the Surviving Sepsis Guidelines, 2021 guidelines. None of them, I think none of these papers could find an association between early antibiotics and survival benefit. I think I could go on quoting many of papers which could not demonstrate an association between early antibiotics and survival benefit. I think Dr. J.V. Peter will be very interested in this. This is a meta-analysis and systematic review. Though some of the papers which was included in this meta-analysis were not of very good quality, but they could not find any difference between the immediate and early antibiotic group and probably the survival. So the immediate group is the one where they gave antibiotic within an hour, and the early group is the one where they gave antibiotic within 3 hours window. And this another paper where they extended the window and they took it up to 6 hours and they tried to find an association between these antibiotic given in 6 hours and any survival benefit. So even in this paper, which is a well conducted research, they could not find a benefit. This is from the Korean group of investigators, and they tried to find an association between patient with sepsis and septic shock. They were able to find a survival benefit in patients with septic shock group, but they could not find an association in the group with sepsis. I'll skip this for want of time. So keeping all this in mind, I think the surviving sepsis guidelines have moved on. They applied this, and probably now I think they have brought some sense to it, and they now recommend us to make a differentiation whether this patient is in shock or not, and how certain are you about the diagnosis of sepsis. If you are certain about the diagnosis of sepsis and the patient is in shock, probably you are justified in giving the antibiotic in the first hour. But in case you are not sure about the diagnosis of sepsis and the patient is stable, probably you can evaluate them, investigate them. You can take up to 3 hours, and if you are still not convinced that you don't have an alternative diagnosis other than sepsis, you can give antibiotic. And after all these surviving sepsis guidelines, the quality of evidence has been very poor. I would also like to bring in here the recent review which was published in the JAMA by Mervyn Singer, which they clearly reiterated there should be an equilibrium when we prescribe antibiotic for sepsis, and the treat first and ask questions later is a very dangerous approach, and there are a lot of difficulties you have, like in diagnosing sepsis, and there could be a possibility that we are overdiagnosing sepsis and we are trying to use antibiotic irrationally. So if you ask me now, the antibiotic administration in the first hour of sepsis, is it feasible? I am sure it is not possible. Does it reduce mortality? I am not very sure with the existing literature. Does it harm? Certainly does it harm. I think we are in an era of antimicrobial resistance, and we are in an Indian subcontinent, and we should be very judicious in prescribing antibiotics. I think if we create a culture that I think you need to give antibiotic fast, you need to give early, and if you put this kind of pressure, I think there is going to be a lot of irrational practice of antibiotics, and I would like to leave with this message. I think every second does it count, but it is reasonable and there is a good rationale to treat sepsis and septic shock promptly, rather than simply throwing antibiotics at patients where you have not done a proper evaluation, where you have not done ruled out septic mimickers, and you have not thought of source control. I think I will leave it like this. Thank you.
Thank you. So that is a very strong and very practical argument in the debate. With this, we'd like to invite Dr. J.V. Peter. I don't think Dr. J.V. Peter requires any introduction, so everybody knows him. To counteract whatever Dr. Siva Kumar has said, and to establish again what we normally teach and normally preach in our day-to-day teaching.
I want to submit to you all that antibiotic administration within 1 hour reduces mortality and sepsis, and it's certainly not a myth. I think the scientific committee members wanted to spice up the session, and so they, twisted the topic and put it in the way they put it. Normally, when you state null hypothesis, you would have given the topic as antibiotic administration within 1 hour does not reduce mortality and sepsis, and then you reject the null hypothesis and accept the alternate hypothesis. But here they've given us the alternate hypothesis, but also rejected it by saying it's a myth. I think the scientific committee also strongly feels they want to question this common belief that antibiotics within 1 hour reduces mortality. Now, I want to use this term myth. Myth is a very strong term. It's used in things like mythology, where you say it's not true. It's a widely held but false belief or idea. So in brief, the scientific committee is trying to say it's all fiction. So their inference is, do not believe that antibiotics within 1 hour reduces mortality. And my colleague and friend supported the committee's biased position and said antibiotic administration within 1 hour does not reduce mortality. I want to break this bias. I want to place before you 4 levels of argument. First is the logic. Second is some statistical basis. Third is evidence. And fourth, an illustrative case. The simple logic, why wait? Our forefathers taught us a stitch in time saves 9. what is gained by waiting? Dr. Shivakumar so elegantly said, diagnosis is not clear, I need more proof that it's sepsis, but delay can be detrimental. You can always start and pull back. You don't need to keep on going with the antibiotics. The concept of early therapy is not new to critical care. We know that time to treatment impacts outcome. We know that for the myocardium, for the brain, and for the golden hour in trauma. I want to emphasize this word called life-threatening events. You don't need to start antibiotics with a first sneeze and say within an hour the patient is going to develop sepsis or is septic and start antibiotics. We all know the story of Hans Brinkler, how he plugged the leak in the dam early so that catastrophe didn't happen. Don't you want to plug the reason for the leaking capillaries? I want to place before you some statistical aspects. How should the question be framed? Do you want to show benefit if it is administered early within the onset of sepsis? Or do you want to show harm if treatment is delayed? I think the latter is much easier to demonstrate than the former because there are some ethical concerns also in designing a randomized controlled trial, randomizing patients to early treatment versus late treatment. So this whole question of retrospective and cohorts is needed because you need cohort studies because you can't do a randomized controlled trial. Now, there are negative trials, but I think many of the negative trials are underpowered to detect a difference, and it's due to a type 2 error. We currently lack tests that are very specific. We have very sensitive criteria to diagnose sepsis, but not specific criteria. And I think a time will come when the ambulance person will do a blood test at point of care and say this is a high probability of sepsis, like we do an ECG and say it is acute myocardial infarction, and the time is not far away. I also want to place before you some of the lessons we have learned from streptokinase and myocardial infarction. There were 35 trials on streptokinase between 1959 and 1988, and a significant benefit of use of streptokinase was achieved in just after 8 trials. And the remaining 25 trials, which recruited nearly 35,000 patients, did little to the odds ratio except narrowing confidence interval. So there was a 15-year delay in implementing a beneficial therapy. Let's not make the same mistake again. Remember, the absence of evidence does not mean the evidence of absence. Here, it's not the absence of evidence, as I will show you, but mixed results. And this is because of the lack of consistency in how you diagnose, defining the right patient population, and type 2 error. Moving on to evidence. Let's start with the retrospective studies that Dr. Shivakumar feels are not good quality. The first one, Kumar et al., we are all familiar with this study, which is not small numbers, 2,731 patients, 14 ICUs. They showed a very strong relationship between delay in antibiotics and mortality, and the adjusted odds ratio was nearly 1.2. And every hour of delay increased mortality by 7.5%. And if you administered antibiotics within an hour, 80% survived. The second is a larger study published in 2014, 17,990 patients, ICU patients, not small numbers. Again, they showed there was a steady increase in mortality if the time to administration was delayed. And within the sub-cohorts, severe sepsis, septic shock, both showed this difference. Even bigger study, 35,000 patients, 21 emergency departments in the US. Median time to antibiotic administration is 2.1 hours. So it is feasible, possible to administer antibiotics within an hour. He talked only about patients who are coming from home, but what about patients in the hospital, patients in the ICU who deteriorate due to sepsis? They can be administered antibiotics within an hour. And again, they showed odds ratio, which was significant in terms of delays. This study showed that there was an increase in absolute mortality for each hour of 0.3% for sepsis, 0.4% for severe sepsis, and 1.8% for sepsis with shock. And all of them were statistically significant. So there are prospective studies also. This is a Medusa prospective multicenter clustered randomized trial published from Germany, which involved again fairly large number of patients, 4,183. And this looked at two modes of therapy. That is basically one where there was multifaceted education that was given to certain intensive care units, and where the other units were randomized to conventional education. And there they found that the 28-day mortality was 35.1%. And unfortunately, a multifaceted intervention did not reduce the time to antibiotic administration, which tells us there are logistic issues sometimes of administering antibiotics within an hour. Again, in the study, when they looked at the entire population, they found that the risk of death increased by 2% per hour delay of antibiotics and 1% per hour delay of source control. So again, we have now prospective trials showing this. Another one from Korea, published in 2020. Again, if you look at the groups that have received antibiotics within an hour, which is a reference, and compare it with those who received antibiotics beyond an hour, there is an increase in mortality. A further one, another prospective trial from Korea. These are patients who presented to the emergency department. 19.8% presented in shock. Again, the adjusted odds ratio for in-hospital mortality for time to antibiotics within 1 hour was statistically significant, and the effect was more pronounced for shock. Now, this is another popular study that is quoted for lack of benefit. This is a fantasy trial which was published in the Lancet, which also recruited 2,000 odd patients, but these were patients who were in sepsis but not shock. So these were patients who did not have life-threatening sepsis, they were not in shock, less than 10% needed ICU, and only 8% died. So the point I'm trying to show here is that if they're not too sick, not sick enough, they are not the population of your interest. The population of interest is severe sepsis and patients with shock. Now, Dr. Sivakumar showed a meta-analysis which was very poorly conducted, but there are two good meta-analyses, one published in 2017, which showed benefit with early on the left-hand side. The one on the right, which is more recent, showed harm with delay. There are two meta-analyses which did not show benefit, and they had methodological problems. I'll finally talk about an illustrative case that I managed 2 weeks back. 41-year-old patient, previous renal transplant, rejected, currently on maintenance dialysis through a tunneled left IJV catheter. Presented with tiredness and decreased intake for 2 weeks. No fever, no localizing symptoms during dialysis, just stopped blood pressure to 60 systolic. Was given 4 liters of fluid resuscitation, and we did a POCUS. IVC was collapsed, cardiac was normal, counts were normal. Patient went on to 30 mics of NORAD. Would you have given antibiotics within an hour? Anybody would have given antibiotics? Okay. Within 12 hours, blood culture grew gram negatives. Surviving sepsis campaign, yes, already mentioned. So I want to summarize by saying, is there a logic for early antibiotic administration for sepsis? Yes. Should we make the same statistical mistakes that we have made in the past? No. Is there evidence for benefit? Yes. With retrospective, prospective trials, meta-analysis. Is there harm with early administration? Not if you pull it out after you've got a negative diagnosis for sepsis. So I want to say that there are compelling arguments that are placed before you. Would you delay antibiotic administration to your loved one with suspected septic shock? If you can touch your heart and say, yes, you can, then your vote is with Dr. Sivakumar, otherwise your vote is with me. I want to say antibiotics within 1 hour reduces mortality in sepsis, and it's not a myth. I rest my case. Thank you.
Very good argument, Dr. Peter. Thank you. Now, can I call back Dr. Ram Rajagopalan back to the dais again for a balanced view?
Anybody who knows me knows it's uncharacteristic of me to take a balanced view of anything at all. I'm clearly an extremist of some kind or the other, and it is very likely that my so-called middle path may also be an extremist point of view. Okay, so empirical antibiotics within 1 hour in sepsis. The question is, I should be taking the middle path. Well, I know the most important proponent of the middle path has always been the Buddha. And very few people realize that when you look at the Buddha, you think of him as an ascetic. He was very clearly somebody who rejected asceticism as much as he rejected the other end of avarice also. But probably far more than him, my current hero is somebody very distinctly different, Daniel Kahneman, who is the Nobel Prize winner in economics. He raises the concern of what he calls as adversarial collaboration. The fact that in science, you do not gain anything by having opposing points of view, that we definitely need to do something in between. Controversy is a terrible way to advance science. Debates are normally conducted as a contest, you probably just heard it just now, in which the aim is to embarrass and to focus on the weakest argument of the opponent and to create a summary caricature of the entire problem. This is what he calls as angry science, and angry science is very demeaning. I like his associate Richard Thaler says that angry science dominates in most academic debates, and there is never any light, only heat. It's about time that we need to take a position that grants light rather than heat in this process. And I can always say that when two phenomenally objective scientists look at the same data and come to the opposite conclusions, it is not in a cynical way that because one person is right and the other person is wrong. It is probably because they do have their own motivational biases that make them interpret the data in very different ways. And I'm going to say that if I'm going to deconstruct these positions, that I need to say that both of them probably have some truths that we need to look at very carefully. I'm going to use a very caricatural kind of extremes for the two cases that I'm going to present to try and give you a point of view that will fall somewhere in the middle. Okay, this is again very similar to the nice case that J.V. Peter already talked about. Okay, here is a very clear-cut case. 53-year-old, classic loin pain, burning micturition, high temperature, low blood pressure, high white count, clear pus in the urine. Ultrasound shows you that the kidney is definitely infected. Does it take a genius to figure that this patient needs an antibiotic? Obviously not. And for the reason that this patient needs an antibiotic is clearly this patient is in septic shock. We know exactly where the source is. We are very likely to be able to presume what the organism is. In India, with a gram-negative sepsis of that kind, which is what it probably is, we do understand that we can even make an appropriate selection of an antibiotic under these circumstances. But life is never that simple. The majority of our patients don't fall into these nice little categories. So let me just look at the rationale that we have. Empirical antibiotics is frankly irrational in the sense that if you give an antibiotic before you know what the infection is, you're obviously doing something that is illogical. But I think we also need to emphasize that when we say empirical, we do not mean empty-headed. When we are going through an empirical process, we try to rationalize where the site could be, what the organism is likely to be, and then we try to make guesses about what we think is reasonably appropriate. And I don't think that this is completely irrational. But I think what we need to look at very carefully is the thing that has been sort of forgotten over a long period of time. The initial clinical trials, these are phenomenally small trials and single-center trials, focused on the importance of not just the timing of the antibiotic, but also the appropriateness of the antibiotic. They very clearly said that if you get both your timing and your appropriate selection, you're likely to reduce your mortality quite significantly. And over a period of time, thanks to, again, Professor Anand Kumar and other colleagues, we have been seduced by the importance of time. We seem to forget that the importance or the correctness of the antibiotic is also equally relevant in the process of this decision making. To the point where if you look at all your surviving sepsis guidelines, I almost want to say you have to survive those sepsis guidelines if you want to do anything good for you. Okay, surviving sepsis guidelines ultimately comes to the same kind of a conclusion, though they may have tempered it a little bit. The fact of the matter is they keep emphasizing that and administer antimicrobials immediately. They don't say appropriate at any point. They say immediately, and that seems to be the focus of what they do. I have to accept that this is a little too dogmatic, and as a consequence, I think we need to be very careful about how we look at all this data. Let me just go back at looking at Anand Kumar's data. This was a series of 3 retrospective cohort, not 1 cohort. He mixed them all very nicely, and over a period of time that extended my entire lifetime, at that time at least, my entire career and beyond in terms of critical care. And there was no standardized way in which the resuscitation or the treatment was performed in all these groups. And please remember, they had a culture negative of about 30% of these cases. And what is appropriate and inappropriate under those conditions, or what is the value of timing under those conditions, we really are not very clear. When you look at other sets of data, they don't seem to have the same strength of evidence. This is again from the MShockNet study, which is a prospective randomized controlled trial for other purposes, but they did have a better quality data and a better standardization of the processes, and they were clearly unable to demonstrate the kind of time trend that Anand Kumar was emphasizing. The way I look at it in this particular case is, okay, you have a suspected infection, you feel that you will confirm it in the majority of times, you treat with an appropriate antibiotic and you give it fast enough, your presumption will be that you will have a good outcome. Little bit of an ignoring of the other side of the equation of potential adverse reactions, and I would say this is the blind man and the elephant, because we need to look at this times when we will be wrong in terms of our diagnosis, and we can potentially create problems with the use of the antibiotics in these given patients. So with this in the background, I thought I will take a different case scenario, or rather, I will take the same case scenario and screw it up as much as I can. Okay, so here, look at this. The same patient presented when I was at STIX. Okay, this is called BRICS, is it? Okay, I was in STIX 23 last year when my colleague decided to provide care for the patient. He decided to give the patient BLI within the first hour. He gave it within the first hour, okay? And the blood culture later reported gram negatives, which turned out to be an E. coli rapidly identified and subsequently was shown to be BLI sensitive. He continued to support the patient, okay, and I'm just creating a scenario where, despite the fact that he gave it early, he gave an inappropriate antibiotic, and the patient progressed on to develop every complication that you can have, including ARDS, goes on a ventilator, gets a line, gets intubated, everything else happens, and then on day 6 develops a fever. This is typically what we will see in the ICU, the nosocomial infections that we will see, okay? And here is somebody who's got a temperature, drops the blood pressure, shows no clear worsening, but has got at least 3 different sites. He's got a kidney that has got a stent, he's got a central line, and he's got an intubation at this point in time. Do we know he's septic? Absolutely. But can we make a decision about the antibiotic within the next hour? And here is where I have certain problems. Number 1, to start with, the diagnostic certainty, or at least of the site or of the organism under these conditions, is going to be quite debatable. This is a study that is a long time ago, an observational cohort in 8 ICUs, European and American ICUs, where they started empirical antibiotics and then subsequently adjudicated whether the patient genuinely had an infection or not. And what they saw was patients who had a confirmed or a non-confirmed nosocomial infection were still treated quite aggressively, okay? And when you did that, okay, about 80% ultimately didn't have an infection, and it is very likely that a vast majority are probably going to be treated early, are going to be treated inappropriately. What is the problem of continuing the antibiotics at this point in time? There is a clear association that if you continued antibiotic in a patient without nosocomial infections under these conditions, their odds of dying was significantly greater. So if I was to look at it, it is not risk-free to continue the antibiotics in a situation where your diagnostic certainty is already very low. And subsequently, it is very important for us to recognize that even when we are making the decision about the antibiotic, the resistance pattern definitely affects it. In India, where I'm going to talk about carbapenem resistance, or the fact that we are literally screwed in terms of the way we can handle our antibiotics, there is a definite concern that selecting the appropriate antibiotic is going to be frankly impossible. Or if I was to look at it completely in a different way, this is going to happen where I'm going to have a dominant negative effect rather than a positive effect. And the selection of an early appropriate antibiotic is going to be frankly impossible under many circumstances. This is a decision analysis on VAP come from almost 1996, where they used empirical therapy and they showed that the mortality in both patients treated empirically with an antibiotic and without an antibiotic were exactly identical. The reasons that they said was the same ideas. The diagnostic uncertainty was extremely high, and the fact that colonization with resistant strains was a serious concern. I only wish we had listened to this kind of data a long time ago. So if I was to put the collaborative middle path and say, we recognize that empirical antibiotics are valid if they meet these two preconditions. That is, your diagnostic certainty has to be reasonably high and your rates of resistance should be low. And if you say a 1 hour limit is something that we should be using, I would rather use it as a slogan that emphasizes the urgency of the therapy rather than a process that I need to compel on people as a clinical standard, NABH or whatever else that you're going to use. Okay? And that is probably what we need to clearly emphasize. It is important to give it early, but we cannot give it early very often. And when we can give it, we give it. If we can't give it, we don't fret about it, is what I feel about it. Thank you very much.
Thank you, Dr. Ram. I have to say, as you said in the beginning, you have taken a stand.
I have, actually. That's what, like I said.
Yes. Can I take
and
a quick
right.
vote? How many of you think early antibiotic within 1 hour is a myth? Dr. Ram Rajagopalan, given the circumstances at this time, he feels it is a myth.
No, it clearly depends on the circumstances. That is what I'm really emphasizing. There may be situations where it is reasonably obvious. The source of the infection, the nature of the infection, okay, is reasonably obvious and we can easily give the treatment, as I took in that first case. But there are many times when we actually fall into a lot of ambiguity where we cannot do that. I think that is the position that we need to take. It is not that one is right or the other is right. It is definitely that we feel that we'll have a mix of both of this.
Thank you, Dr. Ram.
So next we have Dr. Sachin Gupta, who is heading Critical Care Department at Narayana Super Specialty Hospital at Gurgaon. Sir is a dynamic and passionate teacher, and it is always a pleasure to listen to him. Sir will be speaking on beta blockers in sepsis. Over to you, sir.
Thank you. I would like to thank the organizers for having me here, and a very difficult topic to give, beta blockers in sepsis. So the topic is, are they running dry? Do we really have this also in our basket to administer to our patients? So we'll go through some data and see what is the present evidence when it comes to beta blockers in sepsis. We all know that sepsis per se is defined as a dysregulated inflammatory host response to an infection and a similar insult, and this causes cardiovascular failure, most commonly first seen as tachycardia. This tachycardia can culminate into atrial fibrillation, and this is associated with higher mortality rate, specifically in patients who are septic and presents with septic shock. Because tachycardia compromises the hemodynamics of the patients with sepsis, so we feel there has to be a therapy to manage this tachycardia, and so per se can it have an indirect effect on mortality reduction. So why was this research question even framed that should we consider beta blockers in sepsis? So during infection, the pathogens, they interact with patient's immune system and they start an inflammatory cascade. Now this produces a systemic response which includes activation of the sympathetic nervous system and releases the catecholamines, more so specifically like beta adrenergic receptors, which stimulates the heart, which leads to an increased contractility, increase in the heart rate and cardiac output in order to cope up with the increased metabolic demands. However, this pathophysiological process also causes multi-organ failure and can lead to a global imbalance between the systemic oxygen supply and demand. And so, this imbalance, which is due to an excessive release of catecholamines, what we commonly call as stress-induced cardiomyopathy, is the major reason that these patients fall into and they have an altered hemodynamics. So, either we give beta blockade to have a myocardial protective effect and also to reduce the cellular oxygen needs. Or we sometimes even stimulate beta blockers in certain subsets where we feel that it may help in improving the tissue perfusion and also improving the cellular oxygen supply. What do we do actually? Do we really stop this beta stimulation? So if I have to look at sympathetic response in sepsis, there are certain acute cardiovascular problems with this and there are certain late cardiovascular problems. So the earlier ones, patients can have vasoplegia, cardiac autonomic dysfunction, ischemic events, atrial fibrillation, and the last or the most dreaded one is if the patients develop stress-induced or sepsis-induced cardiomyopathy. The longer complications could be a long-lasting atrial fibrillation, patients then gradually developing acute heart failure, sudden cardiovascular death, and other complications. So, whenever there is a catecholamine release, patients will have a stimulation of beta 1, beta 2 receptors. We are more worried about predominantly beta 1 receptors because they will increase the heart rate. They will also have some effect on the blood pressure. Eventually, it causes an increase in the inotropy, increase in the chronotropy and oxygen consumption. But if beta 2 receptor stimulation is higher than what beta 1 is there, then it starts stopping the effects of the beta 1 and it starts counteracting. So what will happen? Patients will have a lower blood pressure, lower heart rate, patients can have a lower cardiac output and a decrease in the left ventricular filling pressure. So the catecholamine response is not guaranteed in terms, will it only be a predominant beta 1 stimulation which is going to happen in your septic patients, or the beta 2 effect will take over the beta 1 effect. So the theory says if you have to do a beta blockade in sepsis, the rationale is it attenuates your cardiac dysfunction, it normalizes the hypermetabolic state, it improves coagulation disorders, reduces the catecholamine production, and it also prevents the lymphocyte apoptosis. So the terminology came into the picture was decatecholaminization, which means you are attenuating the inflammatory cytokines, you are improving the cardiac function, and you are also trying to counteract the metabolic dysregulation by administering beta blockers. So to look at these questions, there have been a lot of literature, meta-analysis, certain randomized trials, low quality randomized trials which are there, and we looked at these. So in 2021, this article came where they looked at what is the effect of ultra short acting beta blockers on mortality in septic patients who are having persistent tachycardia after your initial resuscitation. So this was a systematic review and a meta-analysis where they looked at 6 randomized trials, and what they found was esmolol or landiolol, depending on whatever was being used, it had a positive effect on mortality. The patients who received esmolol had a reduction in mortality in patients with persistent tachycardia. When they looked at other parameters, so they also looked at was there a control in the heart rate. Yes, there was a positive response when these ultra short acting beta blockers were used, but was there a fall in the blood pressure or was there a need to increase the vasopressors? They were not statistically significant. So it gave us the evidence that yes, if you are using an ultra short acting beta blocker in a titrated dose in patients with persistent tachycardia after your initial fluid resuscitation, you may not need to increase your vasopressor and you may still have some mortality benefit. But there were limitations in this meta-analysis. All these studies were very smaller in size. Secondly, the primary outcome in most of these studies was reduction in the heart rate, because they looked at if you are reducing the heart rate, was there an increase in vasopressor, and none of them looked at mortality as a primary outcome. It was an outcome which they also figured out at the end of the study. And hence, they were not able to conclude that this mortality reduction was primarily because of beta blocker. Is there an anti-inflammatory effect of beta blockers, or this is primarily because of the heart rate control? They said that this systematic review and meta-analysis suggests that esmolol or landiolol used in patients with persistent tachycardia can significantly reduce the 28-day mortality. Another trial in 2020, this was a randomized trial, and also they looked at what is the efficacy, safety of beta blockers in septic patients, and they found that there was a marked reduction in the ICU length of stay as well as 28-day mortality in patients who received beta blockers as compared to the placebo. And they also concluded that if you're using beta blockers in ICU septic patients, it reduces your heart rate, ICU stay, and the 28-day mortality. A recent review article, 2024, and they looked at, is there something new? Should we really think about beta blockers in septic patients? And they looked at 11-12 clinical studies which were published from 2019 to 2021. And the primary outcome in most of these studies was looked at, is there a mortality difference? And none of these studies was very confident in showing that there was a major mortality reduction when it comes to beta blockers in septic patients. Yes, there was a reduction in the heart rate, there was a improvement in the cardiac output, the vasopressor need did not increase much, but when it came to mortality, none of the studies was sure enough, and they said, yes, there is evidence that probably you may have a mortality reduction, but don't start using it very early in the disease course. Do your initial resuscitation, at least have a time frame of roughly around 12 hours after the introduction of vasopressors, and even after that, if the persistent tachycardia is there, then think of using esmolol or landiolol, whatever is available. Recent 2024, where they again looked at a systematic review where what is the use of ultra short acting beta blockers with vasopressors and inotropes. The ICU stay, when they looked at the mortality, when they looked at the evidence was actually low, and they said it may reduce a 28-day mortality, but when it looked at other data, ICU stay, heart rate control or vasopressor dose requirement, they could not make any recommendation because the data quality was very, very low in terms of looking at these numbers. So mortality reduction, yes, it was better, but if you look at this forest plot and if you look at the heterogeneity, 86%, right? Not a very good data quality. The patients were not homogeneous in terms when they were looking at. Whereas when you look at the vasopressor need, there was hardly any increase in the vasopressor P of 0.95. So they said, yes, it is associated with better heart rate control, and as per them, as per this meta-analysis, they said, yes, there could be a benefit in terms of mortality reduction. In 2022, esmolol was looked at in septic patients, that can it help in reduction in heart rate along with the mortality, and they found that the esmolol did help in reduction in the heart rate, but it did not increase the vasopressor requirement. The article could not comment upon the mortality part. They said there was no hardcore evidence of beta blockers reducing mortality when it comes to pure septic patients. Since then, there have been quite a few articles, and even the expert consensus statement is there about the use of beta blockers in sepsis, and all have concluded a similar point. Yes, it can reduce mortality if this is given for a secondary tachycardia. So when they say secondary tachycardia, they are meaning that patients should have been fully resuscitated. They should not be associated with a cardiac dysfunction, and after that also you say there is tachycardia, you may still think of doing it. So to answer all this, a recent trial in JAMA, which is the stress-L randomized trial, where they looked at what is the role of landiolol in organ failure in patients with septic shock, and this was conducted in 40 ICUs in UK. What they looked at was ultra short acting beta blocker infusion versus the standard care, and they looked at SOFA scores at 14 days after the trial entry. Surprisingly, none of the factors, whether that is SOFA score, secondary outcome was 28-day mortality, 90-day mortality, length of ICU stay, or even dose of vasopressors, none was statistically significant. And this study has to be terminated, stopped early, because they found that this is probably causing more harm when you're using beta blockers as compared to a placebo therapy. And so it was stopped after recruiting 126 of the 340 proposed patients, because it was unlikely to demonstrate any benefit should recruitment have continued, and there was a signal of a possible harm. And so they said this use of esmolol or landiolol should only be done in clinical trials and not in practice. And this is the latest literature which says that probably the use is still not very sure. So there is very, very limited high quality RCT when it comes to this question, that should we really think about starting esmolol infusions in patients with persistent tachycardia. Recent JAMA trial does not recommend ultra or short acting beta blockers. The rationale which was used is that yes, if you control tachycardia, probably you are limiting the tissue anoxia, but still you are not very sure in terms of what is the effect on mortality and other secondary parameters, and this should be an individualized therapy, and you can't have a thumb of rule kind of thing for this. So is there still hope? I am not very sure about it. Thank you so much.
Thank you, Dr. Sachin. Excellent talk. We will take few questions before closing the session. Can I request all the speakers to come onto the dais, please? And to save time, if anyone has questions, yeah, please come to the mic, and you can start with